Okay, welcome back to the deep dive. Today, we are jumping into a really critical topic, especially if you're deep in revision mode right now.
Absolutely.
We've got this stack of high-yield MSRA notes you've shared, and we're going to crack them open.
That's right. Pediatric hypertension. It's one of those areas that's just incredibly important to get your head around,
Right.
not least because, well, it's often silent, isn't it? But it has serious long-term consequences.
Hmm.
So our mission in this deep dive is basically to go through these notes, section by section, and pull out the absolute core high-yield stuff you need for revision.
Think of this as a focused guide, yeah. Straight through the most important points in your source material. We're cutting out the noise.
Exactly. Clarity and recall.
Okay, let's unpack this then, starting with the very basics.
Yeah.
What is pediatric hypertension, according to these notes? And maybe just as important, how do we actually measure it properly?
Okay. So at its heart, pediatric hypertension.
Mm.
It's defined by blood pressure that's persistently high.
Persistently.
Yeah, for a child-specific age, sex, and height. The standard definition you'll see, and it's highlighted in these notes because of the USA Working Group back in 2004.
Okay.
It's an average systolic and/or diastolic BP that's greater than or equal to the 95th percentile
Right, 95th.
for that child, sex, age, and height. And crucially confirmed on 3 or more occasions.
Okay, so not just a one-off reading. It needs to be persistent, like you said, 3 or more times, at or above that 95th percentile. What about pre-hypertension, as that mentioned?
Yes, that's covered too. That's the level just below sort of the warning zone. It's defined as BP between the 90th and less than the 95th percentiles.
Got it.
The notes do mention that while there isn't one single standard UK definition as such,
Right.
the approach is very much based on these same norms: age, gender, height.
And getting that measurement right, it sounds absolutely critical. The notes really seem to hammer this point home.
Oh, it's non-negotiable. Honestly, the single most critical factor, using the appropriate cuff size.
Right. Too small gives a false high.
Guaranteed.
Yeah.
It'll give you a falsely high reading every time. The notes mention auscultation.
Huh.
Listening with a stethoscope is the gold standard.
Okay.
Though, obviously, electronic devices are very widely used now.
Sure.
But you also have to be mindful of things like white coat hypertension.
Ah, yes, the clinic effect.
Exactly. Where the child's BP just shoots up because they're in the clinic.
Mm.
And then there's the flip side, masked hypertension.
Which is normal in clinic, but high outside.
Precisely. High at home or school, normal when you measure it. Home monitoring can sometimes be a useful alternative to doing the full ambulatory BP monitoring in those cases.
So if you're revising this, key definition points. The 95th percentile on 3 or more occasions bit is vital.
Definitely.
And the absolute necessity of using the correct cuff size, getting the measurement right, is step 1.
Those are absolutely facts to lock into memory. High yield for sure.
All right, so we know what it is, how to measure it. The next logical question is, why does it happen? Is it the same sort of reasons we see high blood pressure in adults, often lifestyle related?
That's actually a really key difference the notes point out. In children, hypertension is, well, overwhelmingly secondary.
Secondary.
Meaning
I bet.
it's caused by an underlying medical condition. It's not usually just lifestyle factors on their own, especially in younger kids. This is the case in up to 85% of affected children.
Wow, up to 85%. That's huge. That's very different from adults.
It is. Primary hypertension, where there's no obvious cause, that becomes a bit more common as kids get older into adolescence. More like the adult pattern then.
Okay, so if it's secondary in such a huge proportion, what are these underlying conditions? What do the notes list as the main culprits?
Right. The notes are very clear on this. Renal issues are the most common cause. Number 1.
Kidney problems.
Yes. That could be problems with the kidney tissue itself, that's parenchymal disease, or issues with the blood vessels supplying the kidneys, like renal vascular disease.
So kidney problems first. What else is on the list?
You also see heart abnormalities mentioned. Coarctation of the aorta is a big one, that narrowing of the main artery leaving the heart.
Huh?
Hormonal disorders are significant too, things like Cushing's syndrome, maybe hyperthyroidism, or congenital adrenal hyperplasia.
Endocrine causes.
Exactly. Then there are medications or substances, things like amphetamines, cocaine, steroids, even excessive caffeine or some decongestants can do it.
Right, external factors.
Yeah. And finally, the notes list a few others like obstructive sleep apnea, which is increasingly recognized, pheochromocytoma, though rare, and certain rheumatological conditions.
That grouping seems helpful for revision, renal, cardiac, endocrine, external factors like drugs.
It's a good way to structure it.
But the absolute key takeaway is remembering it's often secondary,
Up to 85%.
and that renal disease is the most common reason.
Exactly. When you hear pediatric hypertension, your first thought should be secondary, and your second thought should be kidneys.
Got it. So, thinking about who gets this, are some kids more prone? What risk factors should we be looking for, asking about, when we take a history?
Yeah, the notes give a really useful list here. Definitely ask about diet, specifically high salt intake, lots of processed foods.
Mm-hmm.
Obesity, especially persistent childhood obesity, that's a major predictor.
Okay.
There's some interesting birth factors mentioned too, specifically low birth weight.
Really? Low birth weight?
Yeah, especially if it's followed by sort of rapid catch-up growth or a high BMI later on.
Huh, okay. What else?
Family history is important. Hypertension or early cardiovascular disease in the family.
Makes sense.
Being male is listed as a risk factor. And maternal smoking during pregnancy is also noted.
Is there anything that seems to reduce the risk? Any protective factors mentioned?
Yes, breastfeeding is noted as potentially protective, which is interesting. And the notes also link it, perhaps unsurprisingly, to other cardiovascular risk factors. Things like high lipid levels, diabetes. They often cluster together.
This risk factor list feels really crucial for guiding your history taking in a clinic scenario.
Absolutely.
The strong links to diet and obesity really stand out, though.
They do. And they point towards important areas for potential intervention later on.
So just briefly touching on the pathophysiology, the notes mention how the blood pressure actually gets high. What mechanisms are listed there?
Yeah, the notes keep this fairly high level,
Yeah.
as you'd expect for revision. They mention mechanisms like increased vascular resistance, so blood vessels tightening up,
Right.
renal dysfunction, the kidneys not handling salt and water properly or regulating pressure well,
Mm-hmm.
hormonal imbalances like maybe excess adrenal hormones, and underlying genetic factors playing a role too.
Okay. Fairly standard mechanisms then. Now, thinking about differential diagnosis, if a child presents with a high BP reading, what else could be going on, according to the notes, besides true primary or secondary hypertension?
Right, you always need to consider other possibilities, things that might give you that high reading or specific underlying causes you need to rule out.
Such as?
Well, white coat hypertension, which we mentioned, just anxiety in the clinic setting.
Okay.
Masked hypertension is also technically a differential to consider, high outside, normal in clinic.
Right.
And then specific conditions that present with high BP but are distinct causes themselves, like renal artery stenosis.
Narrowing of the kidney artery.
Exactly. Or pheochromocytoma, that rare hormone-releasing tumor. These are possibilities to keep in mind or actively rule out.
Okay. Shifting gears a bit to epidemiology, how common is this actually in the UK? And who tends to be affected?
The notes estimate the UK prevalence at around 2 to 5% of children.
2 to 5%.
Yeah. And importantly, that percentage tends to increase with age.
Mm-hmm.
And there's a very strong link noted, again, to childhood obesity.
The obesity link keeps coming up.
It really does. The notes provide some U.S. figures just for context, around 3.6% hypertension, 3.4% pre-hypertension in kids aged 3-18.
Mm-hmm.
And they give some pretty striking figures for obese U.S. adolescents. Over 30% of boys and maybe 30% of girls in that group had hypertension. Really highlights the impact of obesity.
Here's where it gets quite concerning, though.
It does. Because the notes make this absolutely crucial point. Organ damage isn't just some far-off adult complication.
No.
No. It's already being observed in children with hypertension.
What kind of damage?
Things like thickening of the heart muscle, left ventricular hypertrophy, changes in the carotid artery walls, damage to the retina in the eye, and even potential cognitive issues mentioned.
Wow. Organ damage happening in childhood. That's a really powerful point.
It really underscores why finding this and managing it early is just so vital.
Yeah.
The notes also state pretty clearly that it's likely to persist into adulthood unless you find an underlying treatable cause and manage it effectively. So for many, it's not just a temporary childhood thing.
So key epidemiological memory tips here. That 2-5% UK prevalence, the huge link to obesity.
Definitely remember the obesity link.
And the absolutely critical fact that organ damage can happen now while the child is still growing. That really changes the urgency, doesn't it?
It fundamentally changes how you should view the condition. It's not benign.
Okay, let's talk clinical presentation. What does a child with hypertension actually look like or feel like? Is it something parents or doctors would easily spot?
Well, this is another key point from the notes. Often, the symptoms are absent or completely nonspecific.
Silent again.
Exactly. which is precisely why regular BP measurement, especially during checkups or if risk factors are present, is so vital. You can't rely on symptoms.
But if symptoms do appear, what might they be?
Usually that's in more severe cases. And they can include things like headache, perhaps dizziness, blurred vision, fatigue, or maybe nosebleeds. But again, often nothing.
So history taking is absolutely essential, even if the child seems perfectly fine.
Absolutely critical. The notes really guide a comprehensive history here. You need to ask about their past medical history. Think about birth details, growth patterns, any previous illnesses. Medication history is vital. Not just prescriptions, but supplements, over-the-counter stuff, and especially in adolescents, illicit substances.
Right.
Sleep history is relevant. Remember that link with obstructive sleep apnea? Detailed family history, obviously, given the genetic links and clustering of risk factors. You'd also cover other general cardiovascular risk factors, smoking exposure, diet, activity levels.
Okay.
And then do a proper systems inquiry, looking for clues about those underlying secondary causes we talked about, and specifically ask about any symptoms suggesting high DP or even a hypertensive emergency.
And on physical examination, the notes say it's usually normal, but there are definitely key things to do and look for.
That's right. You start with a general assessment, look at their overall health, nutrition, measure height and weight, calculate BMI, all important metrics.
Standard checks.
Then, the blood pressure measurement itself. Check their pulse first, make sure they're positioned correctly seated usually, or supine for infants. Use that appropriately sized cuff.
The cuff size again.
Always. And crucially, measure the blood pressure in both arms.
Both arms. Why is that so important? Is that for the coarctation check?
Exactly. A significant difference in pressure between the arms is a major red flag for something like coarctation of the aorta, where the narrowing could affect flow to one arm more than the other, or to the legs.
Okay, so measure both arms. What else on exam?
You do a cardiovascular exam, listen to the heart sounds, feel for the apex beat, check for murmurs, and always check lower limb pulses, femoral pulses especially.
Also for coarctation.
Yes. Diminished or delayed pulses in the legs compared to the arms' radiofemoral delay is another classic sign pointing towards coarctation.
And the notes list some specific, maybe rarer physical signs that could be really important clues to underlying conditions. What should we actively look for on exam?
Yeah, these are great memory hooks for potential exam questions or scenarios. Look for things like cafe au lait spots on the skin.
Coffee-colored patches.
Exactly. They can be linked with neurofibromatosis type 1, which itself has associations, sometimes with things like pheochromocytoma. Feel the abdomen carefully for any mass, which might suggest a Wilms tumor. Or listen over the abdomen for a bruit, a whooshing sound, which could indicate renal artery stenosis or other aortic issues.
Right.
Look for signs of virilization in a female child development of male characteristics that points towards congenital adrenal hyperplasia. Skin signs like acne, hirsutism, excess hair, central obesity, purple stretch marks, or striae. Those might suggest Cushing's syndrome.
Cushingoid features.
Yes. And then general signs like excessive sweating, palpitations, or a very fast heart rate, tachycardia. That could be clues to drug effects, maybe illicit substances, thyroid problems, or again, pheochromocytoma.
So memory tip for presentation, remember it's often asymptomatic, super important.
Essential.
For history, have those key areas down past history, meds, sleep, family, risk factors, systems review.
Yep.
For the exam, definitely remember checking both arms and lower limb pulses and link those specific physical signs, the cafe au lait spots, the abdominal mass or bruit, the Cushingoid features to their potential underlying causes.
You've absolutely nailed the high yield points for this whole presentation section there.
Okay, great. So we've got a child with a high reading. We've done our detailed history, careful exam.
Right.
What are the investigations the notes recommend? How do we figure out why this is happening and if it's caused any damage yet?
Well, the first investigation is always rechecking that blood pressure properly.
Right, confirm it first.
Confirm it, ensuring you're using the right cuff, the right technique. The notes actually specify using the fourth Korotkov sound for diastolic BP in younger children, maybe the fifth in adolescents, and comparing it to those specific age, sex, and height norms.
Okay.
And remember that point. Younger children, especially those with severe hypertension, are much more likely to have a secondary cause. That really guides how extensive your investigation needs to be initially.
Makes sense. What are the main goals of running these tests then?
The goals are basically threefold. 1, seek the underlying cause. 2, assess for any co-occurring conditions or comorbidities. And 3, detect any existing target organ damage.
Cause comorbidity damage. Okay. So what are the basic screening tests listed for that?
The notes list a few essentials to start with. Urine analysis looking for protein, albumin, blood, signs of infection.
Urinalysis first.
Yes. Then UNEs and creatinine.
Yeah.
That assesses kidney function. And critically, the notes point out to look at the potassium. Low potassium, hypokalemia, can point towards hyperaldosteronism.
Ah, okay. Specific clue there.
Definitely. A full blood count, FBC, can pick up anemia, which might be linked to chronic kidney disease. And a renal ultrasound is usually recommended pretty early on, just to check the structure, the morphology of the kidneys, and the urinary tract.
Okay, those are the basics. What about tests for comorbidities?
Well, a drug screen might be relevant, particularly in adolescents.
Sure.
Fasting lipids and glucose levels, checking for dyslipidemia, diabetes, those common associated risks.
Right.
And sometimes polysomnography, the sleep study, if you strongly suspect obstructive sleep apnea based on the history.
And then looking for that organ damage you mentioned earlier, what tests for that?
For that, the notes suggest an ECG, looking at the heart's electrical activity, and an echocardiogram.
A heart ultrasound.
Yes, to look directly at the heart's size, structure, and function. Specifically, looking for that left ventricular hypertrophy, the thickened muscle,
Okay.
and a retinal examination, looking at the blood vessels in the back of the eye for hypertensive changes.
So ECG, echo, eyes, makes sense. And the notes also list additional, more specialized tests you might do depending on what you suspect after this initial workup.
Exactly. These aren't done on everyone, but based on clues. So if you suspect ongoing kidney disease, maybe a 24-hour urine collection for protein, creatinine, and calculating creatinine clearance gives a much better picture of kidney function.
More detail than the spot test.
Yes. Advanced imaging comes in if you suspect vascular problems.
Okay.
Things like an MRI angiogram, Doppler ultrasound of the renal arteries, CT scan, or even arteriography in some cases, looking for renal artery stenosis or coarctation.
Right.
Ambulatory BP, monitoring the 24-hour monitors, that's key for properly diagnosing white coat or masked hypertension. TFTs, thyroid function tests if thyroid issues are suspected, plasma aldosterone levels if you suspect hyperaldosteronism, perhaps prompted by that low potassium, and plasma or urine catecholamines, or their metabolites like VMA, if you're thinking about pheochromocytoma or maybe neuroblastoma.
And the notes specifically call out checking plasma renin levels. What do those tell you? Why is that useful?
Ah, yes, renin. This is a really useful test for differentiating causes. So high plasma renin levels often mean the kidneys are sensing low blood flow,
Okay.
which happens in conditions like renal vascular hypertension, maybe from renal artery stenosis, or coarctation affecting kidney perfusion. The kidneys release more renin, trying to boost the pressure.
Right. Makes sense.
On the other hand, very low renin levels suggest the body is actively suppressing renin production. This typically happens in conditions like hyperaldosteronism, where you've got too much aldosterone, the salt-retaining hormone, being produced independently of renin. The body tries to shut renin down.
That's a fantastic distinction. High renin suggests renal vascular cause. Very low renin suggests something like primary hyperaldosteronism.
It's a key differential point.
Okay. So memory tip for investigations. Structure it by the goals, cause, comorbidity, organ damage. That helps organize it.
Definitely.
And link those specific tests like the UNEs showing low K+ way or the renin levels or specific imaging findings back to the conditions they help diagnose, like hyperaldosteronism, renal vascular disease, etc.
Absolutely. That structure should make recalling the right investigations in a scenario much, much easier.
Okay, brilliant. We've diagnosed the hypertension, hopefully investigated and found a cause, or determined its primary. How do the notes say we should manage pediatric hypertension? What's the approach?
Right. Management. It always starts with lifestyle modification. That's the foundation, regardless of the cause.
Lifestyle first.
Yes. So encouraging weight control, regular physical exercise, and adopting a low-sodium diet. Reducing processed food intake.
Yeah.
It also includes discouraging smoking and alcohol use, particularly important as kids get into adolescence. The notes stress assessing and modifying all cardiovascular risk factors.
So a holistic approach.
Very much so.
Yeah.
Ultimately, prevention through healthy lifestyle choices and tackling childhood obesity early is key.
When do you start thinking about medication then? When do drugs come into play?
Medication is generally considered if the hypertension is symptomatic, or if there's an identified secondary cause that isn't going to resolve quickly on its own.
Okay.
Also, if there's already evidence of target organ damage like that LVH on echo, if the child also has diabetes, Or simply if the hypertension stays significantly high despite trying those non-pharmacological lifestyle measures for a reasonable period.
Right, if lifestyle isn't enough. What are the suitable drug classes mentioned in the notes? What can we use?
The notes list several common classes. ACE inhibitors are mentioned, alpha blockers, beta blockers, calcium channel blockers, and thiazide diuretics.
Standard antihypertensives.
Pretty much, yeah. They do note that while ARBs, angiotensin receptor blockers, exist and are used in adults, there's maybe limited specific data on their use in children compared to the others.
Okay.
Diuretics and beta blockers are mentioned as having a longer history of use and established safety and efficacy profiles in kids.
Good to know.
And for very difficult to control or refractory hypertension, the drug minoxidil is mentioned as a possibility.
Okay. Now, the notes also have a specific, quite detailed section on hypertensive crisis. This sounds like an emergency and probably high yield.
It absolutely is an emergency, and yes, definitely high yield for revision. A hypertensive crisis is basically severely elevated blood pressure that's causing acute target organ damage.
What triggers it?
It can be triggered by an underlying acute illness, maybe noncompliance with medication, certain drugs, or even psychogenic factors.
And what does it look like? What are the features?
Features can include things like cerebral edema, presenting as confusion or seizures, acute heart failure, pulmonary edema, or acute kidney injury. Really serious stuff.
How might the child present symptom-wise? Does it differ by age?
Yes, the presentation can differ. Younger children might just be very irritable, have poor feeding, maybe fail to thrive, or present with seizures.
Okay.
Older children are more likely to complain of things like severe headache, vomiting, dizziness, visual changes, maybe chest pain.
And getting an accurate BP reading is key, even if the child is, say, having a seizure.
Critically important, yes. Especially if the child doesn't have a known seizure disorder like epilepsy. The seizure could be because of the hypertensive encephalopathy.
Right. And the initial treatment approach is different. You mentioned IV agents.
Yes, completely different. In a crisis, you must use intravenous, IV, antihypertensive agents. Oral meds aren't appropriate for the initial urgent lowering.
And the notes make a specific point about anticonvulsants here, don't they?
They do. It's explicitly stated and important to remember. Anticonvulsants do not treat the underlying cause of the seizures in this context. The cause is the extremely high blood pressure affecting the brain. You need to lower the pressure.
Okay, so treat the BP first. What 5E drugs are listed as options?
The notes mention several possibilities. Nifedipine, labetalol, sodium nitroprusside, or newer rapid-acting IV agents like clevidipine might be used.
And the goal for lowering the pressure in a crisis? Should we bring it down really fast?
No, absolutely not. This is another crucial point from memory. The goal is to decrease the blood pressure towards normal, but gradually.
Gradually. How gradually?
Typically, the aim is over about 48 hours, maybe a bit faster initially, but certainly not dropping it rapidly.
Why not?
Because lowering the pressure too quickly, especially in someone whose body has adapted to being hypertensive, can lead to organ underperfusion, particularly the brain, and actually make things worse, cause ischemic injury.
Right.
So slow and steady with close monitoring, usually in an intensive care setting.
Okay, wow. So for management, first line is always lifestyle changes. Think about meds if it's symptomatic, secondary organ damage, diabetes, or lifestyle fails. And especially for hypertensive crisis. It's an emergency. Use IV meds. Anticonvulsants won't fix the BP-related seizure issue, and lower the pressure slowly, typically over 48 hours. Those are the critical crisis points.
You got it. Those management principles, particularly the crisis ones, are definitely high yield.
Finally, let's look at prognosis and complications. What's the long-term outlook for these children, and what are the real risks if this isn't well controlled?
Well, the prognosis really depends quite heavily on the underlying cause.
Right. Secondary versus primary.
Exactly. If you can find and effectively treat a specific secondary cause, like surgically correcting coarctation, the outlook can be much better than if it's primary hypertension, or if there's already irreversible organ damage, like chronic kidney disease.
Makes sense.
A key fact the notes emphasize is that poorly controlled high blood pressure, starting in childhood, is a major long-term risk factor for serious cardiovascular events, like stroke and coronary heart disease later in life.
And you mentioned before that hypertensive children often become hypertensive adults.
Yes, the notes definitely reinforce this point. It tends to track into adulthood. Interestingly, they note there's no direct long-term data specifically linking childhood hypertension alone to later CVD risk as measured during childhood. It's a slightly nuanced point. But the strong implication is that early uncontrolled hypertension does significantly increase the risk of early morbidity or mortality down the line. And the fact we already see evidence of end organ damage in childhood with uncontrolled BP is a very strong indicator of future problems.
Right, that organ damage point again. So what are the specific complications listed in the notes if it's untreated or poorly managed? What organs are most at risk?
The notes list the key areas of potential damage. Damage to the heart, that LVH, potentially leading to heart failure later, damage to the kidneys, potentially progressing to chronic kidney disease, damage to blood vessels, generally vascular damage, increased risk of stroke, both now and later, damage to the eyes, retinopathy, which can affect vision. Potential long-term cognitive impairments are also mentioned, and overall, significantly increased risk of cardiovascular disease in adulthood.
So it's a multi-system impact.
Absolutely. The notes really emphasize that regular monitoring and appropriate management are just essential to prevent these serious long-term issues.
Okay. So the memory tip for prognosis and complications. Focus on that long-term trajectory, often becoming hypertensive adults. And remember the clear list of organs at risk, both now with potential early damage and later with major cardiovascular events like stroke and heart disease.
Keeping those potential long-term consequences firmly in mind really underscores the importance of the whole topic, doesn't it?
It really does. So what does this all mean then when we pull it all together from these notes? What's the final takeaway?
I think it means that pediatric hypertension, while often silent and maybe seemingly less common than in adults, carries really significant potential for serious long-term health problems, including that organ damage that can actually start during childhood. This makes identifying it accurately, using the right percentiles, the right cuff size, and managing it early, absolutely critical. Despite, the complexities of diagnosis with those charts and the real need to investigate thoroughly for those underlying secondary causes, which are just so much more common in kids than in adults.
It's a different beast to adult hypertension in many ways.
In many important ways, yes.
And given how often it is asymptomatic and might only get picked up incidentally during an illness check, or if a child has specific known risk factors, it really makes you wonder, doesn't it? How could we potentially improve detection rates more broadly in childhood? Are we checking BP often enough or systematically enough? What are the challenges there? That's definitely something to think about.
That's a vital question for preventative health and healthcare systems, absolutely. Food for thought.
Well, we have covered a huge amount of ground today, really gone deep into these high-yield MSRA notes on pediatric hypertension. We genuinely hope this focused run-through has helped clarify things and maybe solidify some of those key facts you need for your revision.
Absolutely. Understanding these core concepts, the definitions, the causes, the management principles, it isn't just about passing an exam. It's really about being prepared to identify and help manage a condition that can significantly impact a child's future health trajectory.
Well said. Thank you so much for sharing your notes with us, letting us take this deep dive together into your source material. Keep up the great work with your revision. Keep reviewing. Keep practicing.
Definitely. And remember, for more resources to help you prepare for the MSRA, you can check out pastthemsra.com.
And also freemsra.com for additional help. We look forward to the next deep dive with you.